It is our pleasure to interview today Professor John Perfect. Professor Perfect is the James B. Duke Professor of Medicine at Duke University School of Medicine. He is also the chief of the Division of Infectious Diseases and a professor in molecular genetics and microbiology at the Duke University School of Medicine. Over the years, Dr. Perfect has accumulated so many accolades and awards. In addition to his current positions, he is the director, Duke University Mycology Interdisciplinary Research Unit. He's a fellow of the Infectious Disease Society of America and also a fellow of the Association for the Advancement of Science and the Academy of the American Microbiology Society. He is a member of AAP, which is the Distinguished Society for Physician Scientists. He's also president of the Mycosis Study Group. Dr. Perfect received his undergraduate degree in biology from Wittenberg University, an Ohio school. Just thought I would put that in. And his medical degree from the Medical College of Ohio in Toledo, another Ohio school. After completing his residency at the University of Michigan in Ann Arbor, he went on to do an ID fellowship at Duke University in Durham, North Carolina. And my guess is since his fellowship, he has stayed there and has flourished as a highly international recognized physician scientist. In addition, he is a PI of multiple NIH-sponsored interdisciplinary antifungal drug programs and also performs many studies in a variety of molecular pathogenesis with fungi, particularly Cryptococcus. It doesn't look like John has even gone to sleep once. He has more than 600 peer-reviewed publications, journal articles, book chapters, books and reviews. He's a member of the Guidelines on Prevention Treatment for Opportunistic Infection involving HIV and IDSA, and he's also been an excellent teacher, winning the Duke University Teacher of the Year Award and received so many mycology awards, the Littman Award, the Rhonda Benham Award, and the Lucille George Award. So, John, how did this all start? Tell us about your growing up years, your childhood, your parents, and how did you decide that you were going to go on from Wittenberg to Medical College of Ohio? What were the roots of your success?
Well, thank you very much. I will give some personal statements to that. Yes, I am from Ohio, Robert. I grew up in Johnstown, Ohio, which is outside Columbus, Ohio. And then I went to Wittenberg and eventually Medical College of Ohio. And believe it or not, I went up north to do my training in medicine at the University of Michigan. Okay, so how did I start this? I don't know. I think that I was always interested in science. I was always interested in these kind of simple concepts of helping people. And I do that to all the physicians or people wanting to be physicians today. Say, why do you do this? And I think it's because you may do it in different ways, but all of you that go into medicine, I think, have a desire to help people. Very simply, to be able to take disease and try to convert it. Now, you're laughing at me a little bit because I personally was an individual that kind of liked to make the diagnosis and give a treatment and the patient gets cured. Okay, that became very attractive to me as a trainee. An infectious disease was something that had that kind of characteristic. You would find something out, you would design something to understand it, and then you would have something to treat it. Now, that's, again, the simpleness to me when I made my choices of 10 or 12 different specialties within internal medicine. Now, what happened to me, like with many other people, is that things change, and I had to change too, because around the early 1980s or so, there was this disease process of immune-compromised young people. And as it turned out, it was HIV. And remember, I was already somebody that was in infectious disease with what I want to do was to cure people. I wanted to make the diagnosis, give them, and cure. I was not somebody that really felt I had a great tool for chronic disease. And not that it's not important, but I didn't want to chronically take care of people with heart failure, people with pulmonary disease or diabetes and stuff like that. I wanted to find it and treat it, and it goes away. Well, guess what? HIV was a kind of a hooker on that particular issue because it was something that, first of all, we didn't have a treatment for. And there were many a nights when I saw young people die from HIV. It's been just a dramatic thing to see the progress that's been made in a disease process where there was no treatment to one that now is a chronic disease process management. I didn't go into it that way. And in fact, the truth of the matter is, for me, just the way my career started, I started seeing a lot of patients with HIV before we had no treatments. And having to deal with the AIDS epidemic and treating patients without treatments, this was a dramatic change for me. Why I liked infectious disease was I like to cure people. It was just the simpleness to it. And all of a sudden, we weren't curing people. So the trauma, the young people dying, was sad for me. But again, I went into this business to try to help people. And I'd have to say, during that time, some of the most important care of patients that I've ever done is probably taking care of patients when I didn't have something to take care of them with. The ability to have to deal not only with patient, but with family and with the general public. And I would have to say again, there were really sadnesses to this thing when I saw how other people treated some of these patients, the modern day lepers, so to speak. It was sad to me. It was sad to me also when my own colleagues in other specialties didn't want their patients to sit in the same room with my patients. That saddened me. But we went through that type of thing, and surely over time, what a remarkable 20 or 25 years. Where now it's a chronic disease process. It's the diabetes, so to speak, of infectious diseases, and made by the people that had to deal with these patients in the early stages of this epidemic to the ability to actually develop treatments and get them to a chronic disease process. My only hope, and I don't know in my lifespan there will be one, is the ability to prevent these infections. I'm talking about a vaccine.
You know what's lovely about what you just told us? It what keeps us in this business, which is you feel much better because we are, as you said, you are helping people. You are helping them to be better. And honestly, sometimes people ask me, "Are you gonna retire?" I said, "No, I'm still enjoying myself, and you and Robert are in the front line of helping people. It is unbelievable. What a pleasure and what keeps you going. It's fantastic to hear this."
I think we all went through that. I remember in 1986, I finished my residency and I went out into private practice and I saw all these young men present with oral thrush. It was heartbreaking to be part of the healthcare at that time when you knew that this was the first sign of AIDS, and when they get admitted to the hospital, then called pneumocystis carinii pneumonia, PCP. It was a rough go. It was a rough go. It would take your heart out when you see these young men move on. And since then, the HIV epidemic, if you will, changed.
I was looking at your CV, and there are certain things which are really very interesting. For example, you wrote something about epidemiological trends in candidemia 2023. So I really would like to see how candidemia changed over the years since you started.
Yeah, I think, Mahmoud, I don't know really how much it's changed. For us, I was looking at it the other day in our own hospital. The incidence of candidemia has been very, very high for many, many years. We're talking 20 or 30 years. This is part of all that we do. The broad spectrum antibiotics that we give, the tubes that we put in every orifice to patients. This is modern medicine, and it's been around for quite a long period of time. I will tell you that one of the interesting things that happened to me recently with candidemias was something that I was kind of suspicious, and I haven't really delved into it yet. But last year or so, we had a reduction in the cases of candidemia that we saw in our hospital. We're a hospital that is kind of full service type situation, and we will see upwards of 120 to 140 cases of candidemia a year. And it reduced down. And why did it reduce down? Well, I think, not that I'm going to be proving this thing, we had a shortage of blood culture vials. And we happen to be a hospital that does 30 mLs. And we had to go to 20 mLs bottles. And I think that's exactly because recently we've been able to go back to our 30 ml bottle type situation. And there are plenty of candidemias out there again. So I think it's at a low level. And I'm just going to tell you, I think the volume does make a difference, I suspect. And we saw it in kind of the natural situation that we had. So I think that what I would say to your question is that it changed a little bit on us because of how we did the diagnosis. I think it's always been pretty high. I think it's going to stay. I'm always impressed with the candidemias when you start doing your statistics and you say, oh, attributable mortality of 20, 30, 40%. That seems really, really high. Well, when we did it, that's what we see. Now, attributable mortality is always difficult for me, okay? It's really, really difficult because these are sick patients with a lot of disease processes and, you know, besides just the candidemias. But it's still something that's kind of remarkable to me that we still are seeing that even today. But I will say, with your candidemias, if there's something I would like to emphasize a little bit more, is I say attributable mortality, but in my heart, many times, these patients with candidemia today are pretty sick with disease processes, and we're seeing them kind of at the end of life. And one of the sad parts to me is that we do these studies year in and year out trying to do candidemia studies in the United States, and we have a hard time doing them today. And mainly because these patients, there's all kinds of things being done to them. It's hard to get them on clinical studies. It is kind of the end of life type situations. Even though we talk about attributable mortality, they are surely at the stages of many other things going on with them. And like I say, I think our incidence is still pretty high, because, you know, we still do a lot of lines in these patients, and we still do a lot of broad spectrum antibiotics. And even though we may push in some antifungals pretty early, it still comes up to bite us. But I think what I would say, Mahmoud, what I see today is it's hard in the United States to do candidemia studies anymore. And some of that, it's hard to get patients on studies. We will screen 50 patients to get one patient on study because the patients are very movable targets with a lot of underlying diseases. That's from candidemias, the evolution to them. And what I've seen today is they a lot of times will occur in pretty sick patients.
What do you see the role of these molecular-based diagnostic methods that are being developed now, non-culture based, obviously, based on molecular signals that people can find in blood samples? What do you think their role will be in the panorama of diagnosing candidemia? In other words, do you think we'll be getting a lot of false positives, a lot of false negatives? What do you see these rapid molecular diagnostic tests play in this scenario?
Robert, it's a good question. I think over time that they will be players because eventually they will be streamlined, they will be validated. We will have to deal with it because, again, you know, all our systems have been on cultures. They have not been on DNA, which is a lot of what these things are, DNA and RNA. I think there's going to be some evolution to these things, but I do see probably over time, they will eventually be integrated into clinical practice. I see them being bigger players. I think it will come over time because it will, in a lot of ways, will end up being cleaner. But there's going to be some evolution, clinical evolution to these things.
And I can tell you something, a number of companies reaching out to me to develop these quick diagnostics, different from PCR also, Robert. So I really agree with you. This is going to happen. And the most important thing is the validation, which I'm glad these companies now are starting the first step towards validating these approaches. So yes, we are going to see more of that.
If I could give you a little bit of my own personal experience recently on these type of testing type things. My daughter, who's a physician here at Duke, and she had a pulmonary disease, coughing, fever, various things. And, you know, it went on and on and on. And she got a couple antibiotics and various things. And guess what? When she went to her primary care doc, is they did one of these rapid tests for 15 different pathogens from her airway. Okay. Well, now we've actually figured out what it was. It turned out after all these antibiotics, all the amoxicillins of the world and various other things that didn't work, she had mycoplasma. Okay. And we made the diagnosis on this testing. It was there. Okay. And guess what? She actually got a decent antibiotic and she got better pretty fast after 2 weeks of fever and cough and everything. So what I want to say to that thing is, I think over time, this testing system and the ability to do these things like Mahmoud talks about will be here. And I'm actually kind of for that because instead of the spiraling empiricism that I've dealt with for the last 30 or 40 years, you know, maybe we might understand what we're actually dealing with. And there's a lot of things out there, and the testing's getting better and better, I do believe.
Listen, you've been doing Cryptococcus for umpteen years, forever. So what I want to ask you is, what is new with Cryptococcus?
Okay, well, since we only have an hour here, I think I'm going to have to be a little bit focused on this thing. It started on Valentine's Day, February 14th, 1978 at 11 o'clock at night. And you go, whoa, wait a minute, I don't believe that. Well, if you look at one of the papers that I have in the back part, it has my note of when I was a fellow and I came to see this patient with cryptococcal disease, that cryptococcal meningitis. That isolate that I had that night that I looked under that Indian ink is one I worked with for 48 years. H99, which I named it H99 after putting in my boss's book at the 99th organism in the human isolate book. That's how it became H99. And we've been able to study it now for 40 some years. I think I want to give you that background to that because this was just a fluke of a night that I'm in there on Valentine's Day at 11 o'clock at night. And it happens to be, you say, well, why were you there and where was your wife? Well, she was a nurse at the time and she was working. And so I didn't have anything better to do and I was called in. I think that type of thing of starting there to give you that foundation that spent the last 48 years to study that one organism. I will tell you that it's more than one organism. As much as I kind of hate and love H99, the organism we started with that we still work with, and it gave us a lot of tools. But what we are trying to do is, with a lot of tools today, is sequence a lot of strains. And H98 is one strain, but what you learn over time is that these organisms evolve and they adapt. And so we should never assume that one organism is telling us everything. And so I think what I've tried to learn and where I'm trying to go is to actually, and have collected now thousands of strains of organisms which we now sequenced so that we can actually see what their structures are like. And so what I think the next 15, 20, 30 years is to be able to see the variability of strains and how they evolve, both on a macro and a micro basis. The second thing I will tell you that excites me, and I guess you're exactly right, I'm still as excited about medicine and research as I was in 1978 when I saw H99 under a microscope. One of the great things that I am trying to convey to you in this day and age with NIH trying to do whatever it's trying to do, or what the government's trying to do to research and to young people and various things, whatever they're trying to do not give up. Do not give up. The system is too good, and there's too much need, and the tools are too great. They're as good as today as they ever have been. And so for the young people, we've got to struggle here maybe a little bit, but hang into it. It is worth it, because what I'm going to tell you is there are a lot of tools here, and we can learn an awful lot. The future is absolutely bright when it comes to science. And for us in mycology, from the old days of reading this stuff and doing the things that we do to what we can do today is dramatic. So what gets me up every morning and what gets me doing these things is the tools are there. The tools are there, and the need is still there. We're still, I hate to say, if we start to play around with PEPFAR and stuff like that, there's going to be so much more cryptococcal disease that we're going to be up to our knees in it, particularly in places like sub-Saharan Africa. And you're asking, there are new drugs or there are new compounds. And for me, I'm a little biased right now, but I'm kind of working on a compound that I think is the best cryptococcal drug that I've ever seen. In other words, I'm being here and I'm, yelling and screaming and being all excited, and it probably will never happen. But I think that with this class of drugs, if it works like it does in the animals, we could someday treat cryptococcal meningitis for 2 weeks and call it a day. In other words, these fungicidal drugs, the ability to make the diagnosis and kill the organism very rapidly. Now, the other thing that I've learned on it is be careful what you ask for. And in fact, doing all this killing and stuff like that of the organism, sometimes the host gets a little revved up. And so the other concept that I think that's very important that I want to leave the young people with is, as much as I focus on the organism, the host is the most. And I think what I've learned over time is that it's really the Goldilocks paradigm day in and day out. And it comes to immunity. Too much and too little. And that's what we deal with a lot. And we got to get it just right. And for treating these disease processes and how we have to do it, these things move back and forth very, very quickly. So that not only do we have severely immune suppressed patients developing these infections, but we have the immune reconstitution stuff where they overshoot. And we have to deal with both the clinical aspects to try to control these infections. And there, I think the art of medicine is still very, very important here, because we still don't have the great tools of diagnosis to know exactly where we're at in the Goldilocks paradigm.
I have to say, every one of my grants is based on a clinical isolate that I found in a patient. I remember in 1984, and Mahmoud, you got to understand, these are like sentinel moments. I remember December 28th, 1984, it was approaching New Year's Eve, and we had a patient at our hospital that had an ESBL bacteremia. And I remember calling Dr. David Schlaze. I says, how do we treat this? How do we treat this? And I went on to keep that isolate. I was a fellow under Dave subsequently when I went back to do my ID fellowship. And, we got the crystal structure of that enzyme for the first time at 0.9 angstrom resolution. How that happened, I don't know. But it was, it's funny how these sort of serendipitous things, in my mind, it reflects our personal involvement in the research enterprise, how much we put our own persona in the work we do. You've been involved, John, in the development and the testing of multiple antifungals that have been introduced into the clinic and in various capacities. I wouldn't want to ask you what's your favorite antifungal because it's probably, now you already told me it's the one that you're developing, so I'm not going to go there. But what were the lessons you learned with each new introduction of a novel drug? What were important lessons as a physician scientist, as a clinician? What did you learn from the introduction of X antifungal? how is it applied to another antifungal that you had the opportunity to test? And what mistakes do you think were made in the evolution of this field that would be interesting to know?
When I started this thing, there was a drug called amphotericin. And I think it appropriately got its name as amphoterrible for a reason. It was niche, it was powerful, et cetera, et cetera. And so I have seen amphotericin from a pretty toxic drug. And actually, I hate to tell you, I haven't used amphotericin desoxycholate in 5 or 10 years. It's gone. It's gone. So we made progress by the lipid products and stuff like that. So we evolved a pretty toxic, potent, broad-spectrum antifungal to one that's more usable, particularly in medicine today. Second thing is I also found the growth of the azole compounds to be extraordinary. They went from nail infections, yeast infections, vaginal candidiasis, to overwhelming candidemias and stuff like that, and different types of things. You've seen these things improve over time to long half-lives, to a little broader spectrum. I think it's just remarkable what we've done from that time of the azoles back when they first started to where they're at today. So I think they're a great story. I think the echinocandins are another great story. They were what the penicillin, so to speak, of fungi. We knew that this thing had to be attacked, and fungicidal type stuff. And I think that the ability to take them into the clinics now, and in fact, you know, they're the standard drugs now for candidemias. I think it's remarkable what they've done. So I think that I would say, without going too much farther in it, each one of those classes has had a story around it, and each one has progressed actually very, very well. Do I think they're perfect? No. And I'll tell you why I think that we need to continue to do it. Not only is it that sometimes don't have the broadness that they need and stuff like that. The other thing that is sad to me on all three of these classes, and it may have to do with drug development and various other things, is I think we've made a mistake. And when we do these studies, these fungal infections need to be treated for a long period of time, weeks, months. No, we shouldn't be thinking about that. Just as I talked to you about maybe someday treating cryptococcal meningitis for 2 weeks. We need to have better drugs that are fungicidal that get in and get out. We should not be keeping these drugs on for weeks and months. Now, we do right now. Don't get me, I'm not changing that game. I'm just saying that our development is where we really need to find potency and the ability to get in, diagnose these things, get in and treat rapidly, and get back out, so that we're not in conflict or in the situation around trying to manipulate or have concern with the underlying disease. Because remember, when you're dealing with fungi, a lot of times you are enwrapped into a very serious, bad underlying disease, and you don't need to be there causing complications like amphotericin B, an azole drug interaction and stuff like that. So I think that's a long answer to a very interesting question. But I think if you look at them, there's nice histories in each one of those three classes. I'm hoping and praying that there'll be other classes and drugs with potency that we could actually end up treating these patients even faster. That may not make it successful for the pharmaceutical company per se, but I will bet it will make it successful for the management of the patients.
So I cannot leave this interview without asking you the question, what about antifungal resistance? Should we be more concerned compared to antibacterial resistance? I would love to see what you guys think.
Okay, let me start it, and then he can come in and set me right, okay? Let's do it this way and say that, Mahmoud, I've published papers on this thing, so you got an idea of my question around antifungal drug resistance and stuff. And it's a multifactorial layer type situation, okay? One thing I would like to say from the fungal standpoint is, unlike with bacteria, there's no classic plasmid-mediated, transposon-mediated drug resistance. I don't think we're in the same class as bacterial stuff. I mean, not to say that you can't develop resistance on these drugs, but I don't think it's quite the same way. What I would say is there is some drug resistance. I mean, look at what's happened with C. auris. There's a moderate amount of resistance with it. It depends on where you're at. I hate to say it, I'll knock on wood here if you want me to do it. I watch how so many people are now overwhelmed with C. auris infections and in some places drug resistance. That's still a very specific for certain locations. We see very, very few cases, and the cases we've seen, which is very little, have been fairly susceptible. So it's a variable situation with drug resistance, depending on where you're at. But I think it does make us be concerned about the ability for drug resistance to develop and occur. But I'm going to tell you the final thing that I see on drug resistance in fungal infections is not as much the mechanistic stuff, which is important, don't get me wrong, but it's what I call clinical resistance. And it's the fact that the patient is failing. They got toxicities or they got other issues of underlying disease and stuff like that. It's what I call clinical resistance. And the fungal infections are usually right in the middle of that because they're very active underlying diseases. And those things will require insights from a lot of different angles with these fungal infections. So I want to say I think there's plenty of resistance that can be out there. There will continue to be. But for me, the biggest component of resistance is clinical resistance, and there's just a whole list of things: of underlying disease, toxicity, PK, all those type of things that go on.
You know, I know we are focusing on more systemic infections, but more recently, I'm sure you both heard about the Trichophyton endotheniae, which really started in India, and now the CDC were interested in doing a survey to see to what extent are we seeing this in the US. And we published a paper with the CDC where we showed that one patient who was traveling from Southeast Asia acquired that. It was sexually transmitted. So it's becoming more complicated than just having resistant to toenail infection, for example. So I think it would be wise for us to start thinking of this more often, because I totally agree with you with respect comparison between the bacterial and antifungal resistant, but this issue with antifungal resistant is really also going up now in systemic as well as cutaneous.
You're absolutely right. I don't want to shortchange that, and particularly on the dermatophytes and stuff like that. You can imagine stuff is done over the counters, various types of things, and what you see is not going to change, and there's going to be more and more of these drug-resistant isolates. And so we, even in the fungal arena, have to realize that we have to be careful of what we do and how we use our drugs, and particularly even the systemic drugs, very careful, because one of the things that we do is a lot of times we treat these patients that have very serious underlying diseases and immunity, and so the burden of organisms can get up quite high. And so this is still a fertile area for drug resistance, whether it's on the skin or whether it's in an immune-compromised host. And so I think we do need to be aware of those things. So I do want to emphasize that I think with bacteria, Robert will have more issues. It gives me even more chills about the spread and the transposons and the plasmids and drug resistance. And I hate to say it, I'm on the fungal side of this thing, and I'm as big a cheerleader as possible to have more antifungals. I'm also a clinician. And actually, the chills that I have are with the bacteria and the lack of development of new drugs with new mechanisms and stuff like that. We talked about it for years and years and years, and I still don't see it making tremendous progress, and that still bothers me and scares me.
We've talked about antifungal therapy, we've talked about antifungal diagnostics, molecular, et cetera, and the evolution of all these different processes. But do you think we will ever have immunologic methods to treat fungal diseases? In other words, will we be giving an antifungal and a monoclonal antibody? Will we be giving an antifungal and a cytokine? Will we be giving a biological modifier in an antifungal?
Yeah, so Robert's absolutely right. When we talk about these things, when we talk about the two things, the host and the parasite, or the host and the fungus. And so we spent a lot of time on the fungus and direct antifungals and stuff like that. But he's absolutely right that that we need to build up the host. I mean, that clinical resistance stuff is important. I suppose, Robert, what I would say, the first area which is kind of interesting in my own arena was gamma interferon. I mean, there's several large studies that are actually fairly positive for treatment in cryptococcal meningitis. And when you look at the pathophysiology, you can see where adding gamma interferon to this cryptococcal meningitis may actually improve the killing. The only concern I have a little bit for that is I think we'll have the monoclonal antibodies. We may have the cytokines and various things. My concern is I'm not sure we're yet right there with the measurement of these patients. In other words, where they're at in their immunity. In other words, we get these powerful things, we put them in, and we can go one way or the other way, maybe too fast or too quick, and that concerns me a little bit. I hope that as we do these things and to develop the monoclonal antibodies or develop the interferons and various things, that we also develop a monitoring system to try to understand where that patient is at in their immunity, because too much is not good either, and too little is not good, and you got to get it just right. And I think we just need to be sure that we can get better on that as we judge them. So it scares me just a little bit to pour all these immune modulators in when you might overshoot. And so I'm all for continuing to do research in this area. I do think there's definite potential there, because the truth of the matter is, if you don't improve that host, all these antibiotics, all these antifungals, all of these, they're going to be mediocre at best.
I looked at the article where you talked, John, about cryptococcus and nutrient acquisition, dining on the host. Again, it brings the host into the picture. So maybe you can tell us a little bit about this.
So one of the things that we study when we study the organism is we study what it does and how it survives and what are its tools. I mean, just think about this a little bit. In Cryptococcus, it's got to live in that host. And there's a few million fungal species, and they don't dine on us very much. They just can't deal with us. Some of that's related to temperature. Okay, so we're kind of hot, and most of these fungi can't survive in that heat. But they also got to be able to grow or replicate in some way, shape, or form. Remember, when you think about fungi, you're only talking about maybe 300 species that have caused disease in humans. They got to live at a hot temperature, or at least they got to survive at a hot temperature, because 37 is still pretty hot. And they got to be able to have nutrients, and they got to be able to survive on these things and have the ability to grow or replicate or survive. So I think some of the fundamental things that we've been studying is, how do they deal with carbon? How do they deal with nitrogen? When I talk about this thing, I think for the next generation of biologists and pathologists and clinicians and stuff like that, think about how they survive in an environment that they may not particularly like, but they get in there and they can cause some havoc. So I think those type of arenas are areas where drugs or vaccines or various things can still be very attractive, because some of these guys, gals, whatever you want to call them, have had to develop tools to survive in a pretty inhospitable environment, which is the human host. Without going into the details of dining on the host, for the people thinking about this thing is pay attention to what that is and what they've had to do, from everything from the chemicals they have, from the irons, from all the stuff that they have. They've had to develop tools to be able to live in the human body. Unlike viruses, which they have to do this, they don't have to do that. They can live out in some potash or whatever they're going to do. So these are very attractive areas to continue to study.
All three of us have been in the academic world for a long time, and all of us have had trainees that have rotated through our labs. We've had the privilege to bring people along in their academic careers and mentor them. Share with us your feelings or your concerns about the future. Are we beginning to lose scientists? How important is the educational efforts we have, and how could we best preserve them?
So Robert ends with one of the toughest questions, one of the most important questions that you've asked me.
Yes.
The answer is I don't have any specifics. What I would like to leave with this type of thing is things may evolve a little bit, but the point is we need to be much more optimistic. We have incredible tools. There are incredible tools here. And I know there's issues around funding. There's issues around evolving healthcare, various types of things. But for the young people getting into this thing, these are snapshots of what we're dealing with today. They will get figured out. The important thing is the principles around these things and the structure that has been developed. And I have never, ever been more excited about the structure of science, of the tools that are there. It is evolving, and it may cause some wobble for a little bit, but for anybody that want to go into medicine, into science and stuff like that, there's never, ever been a better time than now. Even though we may struggle with certain things, these will be transient things. The principles are there. They're being taught. There is resources there, even though they're changing and stuff like that. And there's excitement, and there should be excitement that we can make a lot of progress. We really, really can. And so I'm going to tell you a positive feature is go into medicine, go into science, go into medical stuff. There are unbelievable tools here. And there may be some struggle with funding and various things for a while, but the principles are good. They're solid, and you just got to work hard and be excited. It will be rewarding.
On behalf of Dr. Michael Letterman, the editor-in-chief of Pathogens and Immunity, and the rest of our editorial board, we want to thank you for this outstanding discussion that you have with us. We really appreciate your enthusiasm that we need to press on, and that we are at exciting times. We've learned so much. We can't let this go.
That's a great summary. And for both you and Mahmoud, thank you for asking me. Hopefully I have left with a positive feature, because it is a positive feature. We need to move forward. We have incredible tools. We have incredible people, and it's right there. And for the next generation, go for it.